John Jensen is the supervisor of outpatient rehabilitation of the Valley Hospital. He's here to talk about vestibular therapy and rehab. Welcome, John, and thank you for being here this evening.
Thank you very much, Susan. Thank you, everyone, for attending this presentation tonight on this rainy evening. I do appreciate it. Going to speak a little bit about vestibular rehab and the impact it could have on one's gait and balance. So my objectives for this evening is to identify what systems contribute to our balance, review the anatomy of the vestibular system. This is where we'll get a little bit specific, identify how the vestibular system works, and explain how vestibular rehabilitation can help you. So balance is our ability to control our body in space and distribute our weight evenly in a way that allows you to remain upright. So as a physical therapist, we are constantly seeing patients for their gait and balance for various reasons. And we really break it down into two different categories. One is static balance, our ability just to stand up, maneuver in a tight space, perhaps in the kitchen, perhaps in the bathroom where we are just weight shifting. So that's our ability to maintain the body's center of mass within its base of support. Sounds fancy, but having our feet on the ground, our center of gravity is right about our navel. So in the area that's considered the lumbar spine, about L2, it allows us just to have that subtle weight shifting as we move our center of gravity back and forth. The second category would be considered dynamic balance. This is where we get into walking, running, moving in multiple directions, doing recreational sports, and participating in other high-level dynamic activities. So what systems control our balance? Balance is very, very multifactorial. The three main areas that control our balance are our vision, our somatosensory system, and our vestibular system. So our central nervous system can take a look at these three systems and dynamically adjust them so we can maintain our postural stability and our balance. For instance, say we were walking in the dark, we get up in the middle of the night, need to go to the bathroom, the room is dark. We can't see as well as we would during the day when we have lights on, it's in daylight. Our body has the ability to reweight these three systems. So if our vision was diminished, we use a little bit more of our somatosensory system and a little bit more of our vestibular system. Say we were walking in a busy environment with loud noises, lights, we might rely a little bit more on our vision and our somatosensory system because our vestibular system is just taking all this external stimuli and really causing us to be a little imbalanced because of all the sounds that we're hearing, all the visual stimuli that we're seeing. And thirdly, another example of this would be if we're walking on sand or uneven ground, we go to the beach, we get a little imbalanced. That's our body's somatosensory system that's being challenged. And we would rely a little bit more on our vision and our vestibular system. So I'll jump a little bit more into each one of these systems before we focus on the vestibular system. So vision, our visual system really does help us to regulate the other systems involved in maintaining balance. And as I mentioned, any defect in the visual system can lead to frequent falls and a balance disorder. So just think someone who does not have as clear vision as someone else, someone who perhaps is blind, someone who is walking in the dark. This can really lead to dysfunctions that cause blurred double vision and cause imbalance. The eyes and the vestibular system work together. In fact, the quickest reflex that we have in our body, right? You go to the doctor, they check the reflex on your knees. But one of the quickest reflexes that we have in the body is called our vestibular ocular reflex. And that's the collaboration between what we see and the collaboration with our visual system. So when the head turns, the vestibular system activates the signals to the eyes to move in the opposite direction. This allows the eyes to maintain a stable gaze on where we're walking to. Say we're walking down a hallway and we see the door at the end of the hallway. That's where we want to walk to. If we have skewed vision, our vestibular system will try and take that over, and vice versa. If we have a skewed vestibular system, we're going to rely a little bit more heavily on vision. One of the things I see in the clinic a lot is people who are ascending or descending stairs, and they're going to be wearing progressive glasses or bifocals. Going down the stairs, there's a tendency to tilt the head down and look through the reading glasses. That's going to give skewed vision as we're descending a very tricky situation. I'm going to need to rely a little bit more on the vestibular system. So professional tip is make sure that you're not looking down through those reading glasses, making sure that you're looking through your regular distance glasses. The second system that I talked about is our somatosensory system. And this is the part of our sensory system concerned with the conscious perception of touch, pressure, pain, temperature, position, and movement, as well as vibration, which gives us a sense of movement. And this is what arises from our muscles, our joints, our skin, and our fascia, which is the connective tissue that holds all our body together. So just think, I recently had a knee replacement about 3 years ago, and I no longer have the receptors in my natural knee joint that I had before. So I found I was a little bit off balance whenever I moved to my left. I wasn't getting the feedback from my knee that I used to get. So I really had to train my body a little bit to make other joints and other muscles within my left leg give me better feedback to maintain my balance. Other conditions that may affect the somatosensory system, someone with diabetes might develop peripheral neuropathy. And what that is, you start to get an effect on your nerves where you don't feel your feet. You may not feel the position of your feet. So this is obviously going to affect balance in your somatosensory system. And this is where the visual system and the vestibular system would take over, contribute more heavily in order to maintain our balance. So the joint receptors, as I mentioned, that I had missing in my knee replacement, they can be impacted just by posturing, by injury, or by a surgery, and thus they affect one's balance. Lastly, let's talk about the vestibular system, and then we'll get a little bit more heavily into it. But this vestibular system is a sensory system that is responsible for providing our brain with information about motion, head position, and spatial orientation, where we are, how we move through the world on a daily basis. It's also involved with motor functions that allow us to keep our balance, stabilize our head and our body during movement, and maintain posture. So thus, our vestibular system is essential for normal movement and equilibrium. Information coming from the vestibular system is processed in the brain and then sent on to other organs that need this information, such as our eyes, our joints, or our muscles. Again, this allows us to keep our balance and know what position our body is in. So the vestibular system, it's located within our inner ear, both of our ears, and connected to our brain via the vestibular cochlear nerve, which is cranial nerve number 8. We have 12 cranial nerves. So the vestibular cochlear system, which helps with balance, hearing, and gaze stability. This is information that coordinates the movement between the eyes and the head and provides important information about our posture. When our vestibular system is affected, oftentimes you'll hear complaints about being dizzy, being lightheaded, having spinning. Some of the most common diagnoses that we see within the clinic are positional vertigo, a general sense of uneasiness or dizziness, and certainly people speaking about a general imbalance. We also will hear vestibular hypofunction. I just don't feel like I am steady in the world. I'm dizzy all day long. I'll get into a little bit more specifics about some of the most common diagnoses that we see in the clinic, but without our vestibular system, we wouldn't be able to stand and navigate the world on a daily basis. So as I mentioned, the main function of the vestibular system here is gaze stabilization during head motion. So we're walking down a busy sidewalk. We see where we have to go, yet we have all these other people walking towards us. We have the cars moving next to us. We have the bright lights, the sounds of a city. We need to be able to stabilize our gaze and to see where we're going while we're moving around. That's moving our body, but most importantly, moving our head. It gives us that sense of spatial orientation, where we are in space as we move forward. Postural stability. Without that, I wouldn't know that I'm standing upright. I wouldn't know that my pelvis is underneath my shoulders, my feet are underneath my hips. And it just generally helps overall with our gait and balance. So this is taking a look a little bit at our inner ear anatomy. So you see moving from left to right, our earlobe is where we're going to be taking in our sounds. That goes out into the middle ear, where we have your eardrum, your incus, your stapes, and your malleus. I'm certainly not an ear doctor, but this is where the process of hearing starts. We move into the inner ear, and this is where the vestibular system is located. Most importantly, you're going to see the semicircular canals that sit on the top of the inner ear, and the cochlea, which sits on the bottom of that inner ear. The cochlea is primarily for hearing, and the semicircular canals are mainly for balance. Both of these organs are filled with sensory hair cells that convert vibrations into electrical signals to the brain via the vestibular cochlear nerve, which you see coming out of the right side of this graphic. And then getting specifically into the vestibular anatomy, if you take a look at this diagram here, if you notice up to the upward left, we have the three semicircular canals, the anterior canal, the lateral canal, and the posterior canal. In essence, this sits in either of our ears. It's slightly tilted about 20 degrees forward. Each canal is situated 90 degrees to the other canal, and the semicircular canals detect rotation. So rotation of our head side to side, rotation of our head forward and back. Both the semicircular canals and the cochlea, they're filled with this perilymphatic fluid, and this is where movement happens both within the semicircular canals and within the cochlea. That membranous labyrinth that surrounds both the cochlea and the semicircular canals, this is where you have some perilymphatic fluid. And this fluid, under normal circumstances, should not connect with each other. However, sometimes it does, and this can cause some feeling of uneasiness and dizziness. At the end of each semicircular canal on the bottom, you have the cupula, and this is the widened end at the bottom. The cupula can lead to a condition. This is if we have I'm going to backtrack, excuse me. So within the membrane of the ampulla, we have our otoconia, which detect movement. And as I mentioned, the semicircular canals detect movement in a rotational fashion. And the utricle and the sacculo detect motion in a linear fashion. Sacculo, that's detecting vertical motion, so up and down motion. And the utricle detects horizontal movement to either side, like bending my ear to my shoulder or moving in a sideways fashion. There's otoconia that sit on the walls of those organs. Otoconias are crystals that also detect motion. The crystals can get knocked off and float into the semicircular canals, and that's where we get positional vertigo. I'm sure everyone has heard of BPPV or positional vertigo. The terms are usually used when we think about being dizzy, but vertigo really refers to actual spinning of the world or you spinning when those crystals are floating around in the canals where they're not supposed to be. Those crystals are actually made of calcium carbonate, and they rest on those otolithic walls. The reason the otoliths can detect gravity, and they can also degenerate with age, and sometimes these otoconias get knocked off. Let me just go back here. So some of the common vestibular disorders that we see within the clinic, the most common one is benign paroxysmal positional vertigo, BPPV, as I mentioned. So these are brief, intense episodes of dizziness triggered by changes in the head position. And this is actually a mechanical disorder. So as I mentioned, the otoconia, or the crystals that detect all those different planes of movement, can get dislodged from the walls of that otolith, the sacculo, and move into the semicircular canals. So when we pick up our head to bathe our head, look up into kitchen cabinets, or when we lay down in bed, and we get this episodes of vertigo, which again is characterized as spinning. This is what the head is in a gravity-dependent position, and those crystals are moving through the canals. Those crystals incite a neurological firing, and you're going to get this dizziness and vertigo. Vertigo really is spinning, and this is when the crystals are moving through those canals. The next disorder that we would see is Meniere's disease. And this is a chronic condition that usually affects only one ear and is characterized by regular dizzy spells, often vertiginous in nature, so having vertigo, hearing loss, tinnitus, which is ringing in your ears, and a fullness within the ear. It really does require medical management and vestibular rehab to help manage this condition. This is a disease where you absolutely have to see a doctor. And with Meniere's disease, it's assisted both medically with medications and perhaps even surgery. Vestibular neuritis and labyrinthitis. So vestibular neuritis would be an inflammation of that vestibular cochlear nerve that supplies the neurological supply into the inner ear. Labyrinthitis is an inflammation of the inner ear structures. Both of these can affect our general sense of being upright with symptoms of dizziness, imbalance, and if it gets very bad, even leading to falls. So the important part when we do an evaluation on a person who is referred to us, and we often get referrals from neurologists, ENTs, and primary care physicians. Sometimes the referrals are very specific as to the diagnosis, and sometimes they're just referred for vestibular rehab. It's very important as a vestibular therapist that we identify what the patient's symptoms are and what provokes the symptoms. As I've mentioned, BPPV is a mechanical disorder, and this is due to those dislodged otoconia that enter those canals when our head is placed into a gravity-dependent position. These symptoms typically last less than a minute. They definitely are vertiginous in nature, so you're going to experience spinning, but they can also be self-resolving. So when we talk about dizziness or we talk about vertigo, they actually are two different things. So we try and get a little bit specific as to what the patient is experiencing. Vertigo really does not happen when someone is sitting, walking, standing, and be considered a positional vertigo. You can have vertigo as the onset of some of these vestibular conditions, but it would last longer than what we see with a positional vertigo. So it's very important that we recognize the symptoms. Imbalance, so just a difficulty in maintaining upright posture in any position. When someone has a vestibular hypofunction, and this is when it's not positional in nature, it's not a BPPV vertigo attack, but it is a disorder of your vestibular system, such as a neuritis, such as a labyrinthitis, which is a inflammation within some of the vestibular organs. We see vestibular hypofunctions, and oftentimes this is affecting one ear or both ears, and just maintaining our upright posture can be difficult. This can happen when we're sitting. I'll see patients that lean to one side. They go to stand up, they fall to one side. They have to overly rely on one of the other systems, such as the visual system or the somatosensory system, because their vestibular system has been impacted so greatly. Oftentimes, nausea and vomiting can accompany many of these vestibular issues. I would say it's most common with a positional vertigo, but will often happen as well with some of the hypofunctions that we see within the clinic. And then finally, we'll also see difficulty with vision. When we do an evaluation of someone with vestibular systems, we really try and categorize it into what type of vestibular dysfunction that they are experiencing. And this just goes to a special testing that we do. So we try and break it down into three separate categories if we can. So positional vertigo, we're looking at the symptoms. We're going to be doing some testing that puts them into gravity-dependent positions that brings on those episodes of vertigo. We can also look to see if they're having any central issues. So have you had a stroke, a brain injury? Do you have a progressive neuromuscular disorder that is causing you to have vestibular symptoms? Or do you have a disorder of the vestibular system itself, which again resides in those two ears connected to our brainstem via the vestibular cochlear nerve? And those all come into focus when we ask very subjective questions. Oftentimes, the most important part of our evaluation is the interview process to see what the patient is experiencing, when did it start, what were the circumstances surrounding that initial episode, how long do the symptoms last, what are they doing when the symptoms come on? All very important to lead us in the proper assessment tools to see what is causing the person's vestibular issues. So our goals in vestibular rehab are to reduce the symptoms, right? Alleviate the dizziness or the vertigo. Again, the crucial part of that is identifying which system and which disorder is causing their symptoms. We go through the subjective interview process and then a series of tests to determine what system is most affected within the vestibular system. and treat that one with an individualized plan of care. Oftentimes, balance is greatly affected with anything vestibular oriented. So part of what we're looking to do is enhance their stability and prevent falls. More often than not, many people are extremely imbalanced and at worst experiencing at least one fall. Increased functional mobility is another goal of vestibular rehab. I recently had a lady who had suffered from chronic dizziness for 27 years and just never chose to seek out any medical advice or any vestibular rehab. And really, her quality of life had suffered, tended not to go out very much, tended to stay at home. And she really did have a decreased functional mobility. Her walking endurance, her ability to exercise, to go and tolerate being out shopping was really reduced. So part of what we do once we determine what their vestibular disorder is, treat their vestibular disorder, concurrently we're looking on improving their overall functional mobility. And then of course we want to normalize gait and reduce the unsteadiness that we're seeing to improve upon their balance. There's a particular thing when we have a neurological disorder that we really look at, and that's midline orientation. So a person could have a skewed vision of where they are in space, their spatial orientation, and they could be leaning to one side, and that could cause problems in the musculoskeletal system, and hence their walking. So the vestibular system really does affect a lot of our spatial awareness, our dizziness, our postural stability, and just our overall mobility. So once we're able to identify and treat the vestibular system, we can also work on these other goals of vestibular rehab. And here's some common rehab techniques that we use. So canalith repositioning maneuvers, known as CRT, they're used specifically for BPPV, and this is to move those dislodged crystals or otoconia to a less sensitive area. I'm sure everyone, maybe not everyone, but a majority of the people on here tonight have heard about the Epley maneuver. So this is one of those canalith repositioning maneuvers. It is specifically used for positional vertigo and specifically used for particular canals that are affected by these loose crystals. So if we think back to the semicircular canals that I looked at earlier in the presentation, there's 3 on each side. The most common one is the posterior canal, and that's the canal at the back of the ear. And when we tilt our head back to lay in bed, when we look up into the kitchen cabinets, pick our head up in the shower, this is the most common canal where the crystals move. So when we go ahead and do an assessment, we do a couple of maneuvers, one being the Dix-Hallpike maneuver, one being a roll test, which provokes the symptoms in those particular canals. So we have to identify the canal in order to effectively treat it. So the Epley maneuver, which many people come in being aware of, is not the only maneuver that we utilize. That's used for that posterior canal. But we do have horizontal canals that we get positional vertigo just by turning our head, laying flat in bed. And that would be a different maneuver. They all fall under the canalith repositioning maneuvers, however. The vestibular habituation exercises, we do what is called some motion sensitivity testing. So there's different motions that we would put one through, such as sitting on the edge of the bed or in a chair, bending forward and then coming back up. Does that cause symptoms? Laying in bed and coming up into an upright sitting position, or laying back in bed, does that cause symptoms? Rolling onto one side. These are all motions that may be sensitive to our vestibular system, and cause general uneasiness, dizziness, and a sense of imbalance, but not necessarily vertigo. So these habituation exercises, we're looking to repeat them once they've been identified, and this helps to desensitize the vestibular system so we don't have those symptoms that are triggered by those movements. Probably the most important one next to the CRT maneuvers are gaze stabilization exercises. So earlier I'd spoken about our vestibular system and the ability to stabilize our gaze when we're moving throughout the world. When we do our assessment, we may see episodes of what we call saccadic movement of the eyes. When the eyes are moving involuntarily, we're unable to stabilize our gaze. So there's a few tests that we do to see if the person has the ability to stabilize their gaze while they're moving their head, getting up and walking, moving around in bed, that again are different from vertigo. So these gaze stabilization exercises are used in the majority of patients that do not have vertigo, but have a vestibular disorder. And finally, balance training. So we, as supervisors within the Valley Hospital Outpatient Rehab Department, we have encouraged all of our therapists, when we do any balance assessments, because people come in for gait training and balance quite often, that we do at least a vestibular screening on them, because vestibular disorders can lead to imbalance, as I've mentioned many times. So we would also work on balance training. And we do this through postural exercises, functional activities, and so certainly anything goal-oriented that the patient wants to achieve. So the benefits of vestibular rehab. Obviously, we want to reduce or eliminate that dizziness and get improved control over the symptoms. We want to enhance balance, decrease the risk of falls, and improve one's stability. So falls are not a natural part of the aging process. We should be able to move throughout the world without falling. And we really need to identify why the person is falling. And we do make it a primary part of our individual plan of cares for each patient. Improve quality of life, the increased ability to participate in daily activities and overall well-being. And then certainly empowerment, where patients learn strategies to manage their condition effectively. So I'll use positional vertigo as an example. Once we have identified the positional vertigo and we do a maneuver on the patients, which moves those crystals out of the canals, once we achieve having no longer any episodes of vertigo, I'll definitely teach the patients to be able to do it on their own. Once they're able to identify that it's vertigo versus a general dizziness disorder, patients can then do their own self maneuvers in case they do get vertiginous episodes. In addition to that, just spoke about the gaze stability exercises. Those are something that the patient needs to do on a daily basis. They're exercises that take a minute to complete. So typically you're doing them 6 to 8 times a day. So even after discharge, those exercises will continue for a period of time depending upon the patient's situation. So a big part of what we do in vestibular rehab is patient education. So the patients learn the strategies to manage their conditions effectively. So starting your rehab journey. So in the state of New Jersey, physical therapists have direct access. We are a primary caregiver, so patients can come see us without having seen a doctor. We're able to do our initial evaluation, make an assessment, come up with a plan of care. And then once we establish that plan of care, we send it off to a doctor, typically of a patient's choice, and the doctor signs off on it within 30 days. However, Anything vestibular oriented, I find it's best to consult with your doctor first, because the doctor needs to assess your condition and determine if it needs any medical management or if there's any other further diagnostic testing that can be done to rule out anything non-vestibular. So dizziness can happen for a variety of reasons. It could be a cardiological event. It could be a neurological event, such as a stroke or a brain injury. We want to make sure that those patients get the proper medical management before they start on the vestibular rehab program. Once they are referred to us, we do a comprehensive assessment by a trained vestibular therapist. So within the Valley system, we have 3 outpatient rehab clinics, and we have 3 certified, I take that back, it's not certified, 3 experienced vestibular therapists. There is no certification process that happens with a vestibular therapist. It's just ongoing medical education. And amongst the about 80 therapists that we have, there's only 3 therapists that do that on a daily basis, myself being one of them. So we do a comprehensive individual assessment, and again, looking to determine whether it's positional vertigo versus a central disorder versus a peripheral disorder. And then amongst those 3 categories, there's a lot of subcategories. And this type of individual evaluation allows us to develop that personalized plan of care. And this is a tailored rehab program that is based upon those patients' individual needs that we find during the evaluation process. Then, as with most physical therapy sessions, regular sessions are scheduled to monitor progress and adjust the plan as necessary. I'll compare the positional vertigo to a vestibular hypofunction. Again, BPPV, positional vertigo, is a mechanical disorder. Once we're able to identify the canal and identify the disorder that the patient is having, if it's a simple, recent, acute positional vertigo, they may only need 2 to 3 sessions. If it's a more complicated type, may involve multiple canals, may involve multiple ears, well, they would need more sessions. Patients with a vestibular hypofunction or vestibular disorder, such as labyrinthitis, neuritis, which we discussed, will likely need an extended period of rehab, but maybe not as many times during the course of the week. Once we get them on an established home exercise program, really the success of their recovery lies on that daily compliance with the exercises that we've given them, which can take part at home. So it really is a team approach that we do with all of our patients, get them in as quickly as we can, get follow-up sessions as quickly as we can, and develop that individualized plan of care, because no 2 patients really present the same way. And these are really the specialists that one would see if you are having a vestibular problem. So neurologists, they diagnose and treat balance dysfunctions that is a result of a neurological disorder or a neurological impairment. Ear, nose, and throat doctors specialize in the diagnosis and treatment of balance disorders associated with inner ear disorders, such as BPPV, that positional vertigo, or vestibular hypofunction. They can order specialized testing, diagnostic tests to confirm their suspicions and to rule out other disorders. So that's why it's very important that you go see one of these 2 types of specialists. Primary care physicians, of course, are often the first line of treatment, but even those sometimes get referred out to neurologists and ENTs. Once it comes to vestibular rehabilitation, most of those professionals are physical therapists, and we really are the movement experts in both gait and balance. and those experienced in vestibular rehab are best suited to assess and treat your condition with an individualized assessment and a plan of care. Vestibular rehab is very much a subspecialty of vestibular therapy, so not every physical therapist is going to be able to do that. As I mentioned, we have about 80 therapists within our 3 outpatient clinics, and there really is 3 people that go ahead and treat vestibular disorders. So finally, just a little plug about our Valley Hospital outpatient rehab. We have 3 convenient rehab locations. There's 505 Goffle Road in Ridgewood, which is the original Valley Hospital outpatient clinic. We have 1200 East Ridgewood Avenue in Ridgewood, across from the Duck Pond. That's where I am located. And we have the Valley Hospital Health and Wellness Center up in Mahwah, 1400 MacArthur Boulevard. And we do have a 4th clinic opening up next year in Montvale. Any one of those clinics can be reached for scheduling purposes or to answer any questions simply by calling that central number, 201-447-8131.
Okay.
So in closing, I just want to summarize and say that the vestibular disorders that we see, it's a specific and complicated disorder. It does require special training and special rehab programs in order to successfully treat it. Then you really should start that with your journey by going to one of the specialists that I listed below. Thank you, Susan.
Oh, thank you so much, John. That was really great, so comprehensive and very interesting. Just a couple questions. Just somebody was asking about, well, kind of answered it, but it seems like not every physical therapy facility offers vestibular therapy. And is there any, like, I know that we have vestibular therapy at Valley, obviously, but is there any association that you could like Google to find out, where a facility that does this type of treatment? Is that how it works?
Yes, there's actually, I don't know off the top of my head what it stands for, but VEDA.
VEDA. Mm-hmm.
V as in Victor,
Mm-hmm.
E as in expert, D as in dog, and A as in apple. That will give you physical therapists who specialize in vestibular rehab.
Oh, great. VEDA. Okay, that's
Yes,
helpful. Thank you.
you're
For
welcome.
someone afflicted with occasional vertigo, can techniques be taught when vertigo is not currently present? Or does the patient have to be in the midst of an episode in order to access treatment? I guess
It's
for
an
people that.
excellent
Mm-hmm.
question. So what I see in the clinic, people come in and tell me they have vertigo, and then we determine it's not necessarily vertigo, it's another disorder. So you really do have to have a differential diagnosis that is determined. In addition to that, of course, we do have 3 semicircular canals in each ear. We need to determine what canal the crystals are moving in and in which ear. So the treatment for, I'll use as an example, the treatment for a right-sided posterior canal is the Epley maneuver. But the treatment for a right-sided horizontal canal is a barbecue roll. So you could potentially just continually be pushing those crystals back into the same canal if you're doing the wrong one. So it is something that needs to be diagnosed. 90% of the positional vertigos are in those posterior canals. Hence, we do use the Epley maneuver, but it could be in the horizontal canals. It could be in the right ear versus the left ear. It could be in both ears. I have yet to see it be in the anterior canals, which is in the front of the ear. But if you do the wrong maneuver, you won't get any success. So typically, I would suggest that A, you go to your doctor, and then B, come in for a vestibular assessment. Once we determine what it is, we treat you. Unfortunately, positional vertigo has a higher chance of coming back to someone who's had it, upwards to 50%, the research shows, than someone who doesn't have it. So I always teach my patients on how to do a self-maneuver once we've determined what canal and what side of the ear it is in.
Okay. As far as the three vestibular therapists that are within Valley, are they located in one particular area or
Yes,
across
so
the?
I'm in the 1200 building in Ridgewood, and we have two therapists located within the 505 Goffer Road facility, and we have one person who goes back and forth at the Mawa facility.
Okay, great. And I think you alluded to this, but are these disorders typically diagnosed with an MRI, X-ray, or something else? If you have any idea.
Good question. So they can be confirmed by an MRI. There is also something called the VNG test that either the neurologists or an ENT can conduct. Oftentimes, what I see is going on to a neurologist, going on to an ENT. They'll do their own assessment, refer them to vestibular rehab with a therapist such as myself. And based upon our assessment, it's a very thorough assessment. 9 times out of 10, we're able to determine what's going on with you. And then myself, I use an MRI or VNG testing to confirm or deny what I've already seen. And typically we're spot on. And oftentimes those MRIs and VNG testing will take a little bit while to schedule, get completed, and then be shared with the patient. And oftentimes you're losing out on valuable rehabilitation.
Okay, well, this was so interesting and informative.